It's 2 a.m. You are the junior on call in the neonatal unit, and a call comes in from the labor ward, a term baby, crash C-section for cord prolapse. And the baby comes out floppy, not breathing. You follow the NRP and done PPV, intubation, chest compressions. And after what feels like an eternity, the baby finally has a heartbeat. You transfer the baby to the NICU, and just as you start to think, oh, the worst is finally over, but you notice a subtle rhythmic twitching of the baby's arm, and then the leg. The baby is having a seizure. And you look at your senior, and the look on their face tells you this is far from over. I was that junior 10 years ago. My name is Dr. Oliver, and I'm a pediatrician, and this is Paediatric Squad, where I help medical students or beginner pediatricians to get through the steep learning curve. Today, we're talking about hypoxic ischemic encephalopathy, HIE. And here's what I wish someone had told me clearly on day one. In HIE, you don't have days, you don't even have hours the way you think. You have a single 6-hour window after birth. What you do inside that window can change everything. But what you miss inside that window, you can never get back. So let's make sure you never miss it. What happened to that baby? Let's break it down. Hypoxic means deprived of oxygen. Ischemic means reduced blood flow. Encephalopathy means brain dysfunction. So basically, it is the brain was starved of oxygen and blood, and now it's not working the way it should. HIE falls under a bigger umbrella term called neonatal encephalopathy, which means impaired brain function after birth. So that can be caused by lots of things, like brain malformations, genetic disorders, hemorrhage, stroke, metabolic disorders, or congenital infections. But about 50%, the cause is actually perinatal asphyxia, and that's HIE. And cord prolapse is not the only trigger. Causes like placental eruption, uterine rupture, maternal hemorrhage, or even maternal cardiac arrest, anything that cuts off the oxygen to the baby before or during birth can cause the HIE and lead to neonatal encephalopathy. So why did the senior look so concerned? Because they've seen what comes next. Seizure can occur in about 50% of neonates with moderate to severe HIE. And here is one tricky thing. Sometimes you won't see the seizure at all. They can be just shown in the EEG, which means the baby can have the seizure, but you won't know it by just looking. You only can know it by doing an EEG. However, the seizure is really just the beginning. The long-term consequences of HIE are far more important, like cerebral palsy, lower IQ, the need for special education, blindness, sensorineural hearing loss, or epilepsy. So the senior wasn't just thinking about tonight. They were thinking about this child's entire life. And here's one very important concept. HIE is not just a brain problem. It's a multisystem disease. When the brain is starving for oxygen, the body tries to compensate because the brain is the most important organ. The body will redirect some cardiac output to the brain, but the rest of the body will pay the price. So let's think from head to toe. The lung. The baby having HIE can have persistent pulmonary hypertension or PPHN. The heart. The baby can have myocardial dysfunction and hypotension. The bowel. The baby can have ischemic bowel. The kidney. The baby can have acute kidney injury with oliguria and rising creatinine. And hematological-wise, the baby commonly can have thrombocytopenia. And in terms of metabolism, the baby can have both hypoglycemia and hyperglycemia. So keep this head-to-toe picture in your mind. It's going to come back later. And by the way, if you're a beginner pediatrician and find the math in pediatrics so difficult, I've put together a free pediatric essential formula cheat sheet. You can find the doses and equipment sizes in a PDF. Keep it in your phone. Check out the link in the description. So now, here's the key to understanding everything that follows. The brain injury in HIE is not a single event. I repeat, this is not a single event. It is instead a process that evolves over time. And understanding that process is the reason our treatment works. So do pay attention here. It has 3 phases. So during the initial insult, the cord prolapse or the placental eruption, whatever it is, the brain loses oxygen. And when the brain loses oxygen, the ATP and the phosphocreatinine decrease. This is our energy source. If this decreases, the brain cells can swell, and large amount of calcium can go into the cells, and some cells die immediately. And this process is called primary energy failure. But here was most people don't expect. The initial insult is not where most of the damage happens. After the baby is resuscitated and the oxygen is restored, there's a quiet period called the latent phase. This period lasts roughly around 1 to 6 hours. The baby may look relatively stable, but we can't be happy too soon, because the primary insult has already triggered a delayed self-destruct sequence in the surviving cells. And this latent phase is very important, 1 to 6 hours, because this is the golden window that we can save the brain. So around 6 hours after the insult, the mitochondria which was damaged earlier begin to fail again, even though oxygen is now available. So they can't use it to produce the ATP, and instead the immune response is activated. They can activate the programmed cell death. So you can imagine that they can make the cell commit suicide together, and this is called apoptosis. And this delay reaction after the 6 hours, we call this stage secondary energy failure. And this is actually where the worst brain damage can occur. Therefore, the question becomes, how can we stop it? And the answer lies in that golden period, the latent phase, which is the phase that before 6 hours. So how can we stop it? Our management is therapeutic hypothermia, which basically means controlled cooling. The logic is quite straightforward. So we lower the brain's temperature, then we can slow down the brain's metabolic rate. And the struggling mitochondria are not forced to work so hard. Then they will produce less toxic free radicals. And the immune response is dampened, causing less cell death, which can make a better chance of preserving the brain function. However, not every baby qualifies for the therapeutic hypothermia. Let me walk you through the 3 steps that we can make the decision whether the baby can have the hypothermia or not. So step 1, is this baby near term, or are we within the window? Therapeutic hypothermia is indicated for babies at 36 weeks of gestation or above. So between 35 weeks and 35 weeks plus 6 days is a case-by-case discussion. However, under 35 weeks is not recommended because some study shows that it's actually increased the probability of death. Then the timing. You want to initiate the cooling within 6 hours of birth. Because if you remember the pathophysiology I just told earlier, the 6-hour mark is when the latent phase ends and the secondary energy failure begins. We want to make sure the cooling begins before the secondary energy failure. So how about late cooling beyond 6 hours? So the data suggests that roughly a 76% probability of having some benefit. So it's not completely not recommended. So the AAP now recommend balancing the risk and benefits with a shared decision-making conversation with the parents. So step 2, is there any evidence of perinatal hypoxia and ischemia? You will need objective evidence here. The gold standard is a cord blood gas or the blood gas within 60 minutes of birth. So you're looking for a pH of 7 or below, or base deficit of 16 millimole per liter or greater. But sometimes the gas is not available or the result is borderline. For example, the pH between 7 to 7.15, or the base deficit between 10 and 15.9. In that case, you can look for some supporting evidence, an APGAR score of 5 or less at 10 minutes, or the need for assisted ventilation for more than 10 minutes after birth. If either of these present, you move forward. Step 3, is the baby having moderate or severe encephalopathy? So you can do a neurological assessment with the modified Sarnat exam, or if the baby is having clinical or electrical seizure, then you can define the baby is having moderate or severe encephalopathy. So let's talk about the modified Sarnat exam. Basically, it's just a standardized neurological examination in the neonates. You can use this modified Sarnat exam to classify the encephalopathy is mild, moderate, or severe. And there are 6 categories. First, you look at the baby, the level of consciousness, whether the baby is alert, lethargic, or comatose. And do they have any spontaneous activity like normal, decrease, or absence? What is their posture? Normally the baby will have some flexion, or they only have some distal flexion only, or fully extended. The tone, whether it has normal resistance, reduced, or even absence. And the reflexes, especially the sucking and the moral reflex, where they're present or weak or absent. And autonomic function, for example, heart rate, pupillary response. And in order to classify, you need at least 3 abnormal findings, and the overall severity is determined by the majority. So I strongly recommend you can watch the Stanford Medicine video on the modified Sarnat examination. This is an excellent step-by-step demonstration. I will put the link in the description below. You can check it out. So if all 3 steps are met, the baby is near term, within the window, and the blood gas does not look good, and the baby is having moderate or severe encephalopathy by the examination, or they have the seizure, you should initiate therapeutic hypothermia. And the target core temperature is 33.5 degrees Celsius for 72 hours. All right. So I know there's a lot of criteria to decide to go for the cooling or not. And that's why I've made 1-page PDF to walk you through all 3 steps in one single page. So you don't need to have second guess at 2 a.m. It's free, link in the description. So once the cooling can start, you need to monitor the baby. Monitor the core temperature continuously with an indwelling esophageal or rectal probe, and also run the continuous video EEG all along. Because remember, the seizure sometimes can be electrical only, and you won't catch them without the EEG. And also, you need to watch out the CO2 level and the O2 level, because both hypocapnia or hyperoxia can associate with increased risk of disability. So keep a close eye on the ventilation setting. And remember that head-to-toe picture from earlier is a multi-system disease. You need to actively manage every system. The heart, maintain normal blood pressure. The lungs, monitor saturation and watch out for PPHN. The kidney, track the urine output and the electrolyte and the creatinine level. For the bowel, watch out for ischemic bowel. Monitor the platelets, monitor the blood glucose closely, both hypo and hyperglycemia. So after 72 hours, we can rewarm the baby, but do it slowly. The standard is 0.5 degrees Celsius per hour until the baby reaches the normal body temperature. And at the same time, keep the continuous video EEG running because the seizure can still emerge as the brain temperature rises. Here's something that I want to remind you. Do not let this baby become hyperthermic, because hyperthermic after cooling is associated with 3-fold increase in death or disability. So once the baby is rewarmed, the focus shifts to assessing the brain injury. An MRI is typically performed between day 4 and 7. So these can give us the best picture of damage and also help to formulate a prognosis. And throughout this period, we should maintain the baby at normal glycemia, normal capnia, and no hypothermia. Discharge from the NICU is not the end of this story. The brain continues to remodel over weeks to months, and this is the tertiary phase of HIE. And some neurodevelopmental consequences will only appear much later. And therefore, babies with HIE will need follow-up for at least a few years. And we need to watch out for like developmental delay, behavioral problem, or even some subtle cognitive impairment. So need early referral to some training services and developmental pediatrics. If you still find the developmental milestone is hard to remember, I've made a cheat sheet on the developmental milestone, so you can check it out in the description with other resources. And finally, I think that's the part we always miss. Don't forget the family. The parents of this baby have been through something very traumatic. Mothers of the babies having HIE are at a significantly high risk of postpartum depression, anxiety, and PTSD. Do take your time to sit with them, talk with them, and give them clear expectations. And more importantly, give them the honest answer. Sometimes the best answer is we don't know yet, but we will walk through it together. So now let me take you back to where we started. It's 2 a.m., a baby comes out floppy, having seizure. Everyone in that room is looking at you, but this time your mind is not blank. You know how the injury happened, and you know the 6-hour window is important and you will not waste it. You know the 3 steps that to decide on therapeutic cooling or not, and you know how to monitor, how to rewarm the baby safely, and you also know you need to sit down with the family and be honest about the road ahead. And that's the difference between the junior who freeze and the one who take action. And HIE, that difference is everything. If this video helped, you may put a brain emoji in the comment section. This can help my channel grow, and I will see you in the next video.